Okay, hello everyone, my name is Yutong Zhao and here is my project. My project's name is Towards Optimal SABR Margins in Prostate Radiation Therapy, and thanks to my supervisors David, Martin, Gavin, Simon and Pidgeman. With help, I can choose this brilliant project. Okay, from the very beginning, this project will have three aims. The first one is investigate the accuracy of the treatment delivery and the impact of daily prostate-OAR separation. And the next one is evaluate the class solution from machine learning. And the third one is test this class solution, which we're going to talk about later. Wait, so what is the prostate cancer and where is the prostate gland? The prostate gland is over here, it's really tiny. It's under the bladder and near the rectum. The prostate cancer will have three stages. The first one is early prostate cancer, the second one is locally advanced prostate cancer, and the third one is metastatic prostate cancer. Alright, so in Australia in 2016, there were more than 3,000 deaths caused by prostate cancer, and fortunately, the 5-year survival rate for prostate cancer is 95%, which is really good. And prostate cancer is quite popular around the people who are 60 to 80 years old. So for the prostate cancer, we basically have four therapies. The first one is surgery, second one is cryotherapy, hormone therapy, and radiation therapy. So cryotherapy and hormone therapy is not that effective as most of the time. So these two types of therapy only as a backup option for the surgery and radiation therapy. So for the patients who don't want to lose part of their body, they might well choose radiation therapy. I mean, sometimes radiation therapy is the best option for the patients. The types of radiation therapy. Radiation therapy divided into two types. The first one is brachytherapy, which is an internal radiation therapy. The second one is external beam radiation therapy, is an external radiation therapy. And in this project, we're going to focus on the external radiation therapy. So which EBRT technique we can use for prostate cancer treatment? The first one is VMAT, the volumetric modulated arc therapy. VMAT is an advanced form of the intensity modulated radiotherapy, which is IMAT. The biggest difference between the VMAT and IMAT is the VMAT has the ability to achieve 360-degree rotation while delivering radiation dose to the patients. Hence, in this way, the VMAT could achieve highly conformal dose distribution with improved target volume coverage and sparing of normal tissues. Compared with the IMAT, VMAT has a lot of advantages. The biggest advantage of VMAT is VMAT could significantly reduce the treatment delivery time, which provides the possibility for us to employ the image-guided radiotherapy tool. The next technique is called SABR, S-A-B-R, or the SBRT. Its definition is a precise radiation technique that delivers this high dose of radiation in a small number of frictions to the region of the malignant disease. Since in the SABR we reduce the irradiated area, hence compared with the traditional radiotherapy, the SABR could reduce the side effects of patients and improve the patient's living quality after the treatment. And since the special characters of prostate cancer tumor cells, the SABR is really effective for localized prostate cancer. So does that mean that radiation therapy is perfect? The answer apparently is no. The radiation therapy will cause many side effects, including the bowel problems, urinary problems, and lymphedema. And here is an example about the urinary problems, and here's an example about the lymphedema. Since we have so many side effects, so we need to find a way to reduce the risk of the side effect. One of the best ways is reduce the irradiated area. So for the radiotherapists, radio-oncologists, and radiophysicists, we divided the irradiated area into several parts. The first two parts is called the GTV and CTV, which two parts will be defined by the radiation oncologists. And then we're going to expand these two volumes into internal target volume, the ITV, which will cover the intermotion. And then we're going to expand all of this into PTV, which will cover some displacement error, such as due to the patient's position or the tumor's type or the limitation of the linacs. Okay, the research map. This research will divide it into 3 parts. The first one is called collecting data, second one is called machine learning, and the third one is called testing the plan. So how do we collect data? It's a really interesting question, since we need to rely on some fancy technique which is called the cone beam CT. The cone beam CT is an onboard image-guided radiotherapy tool. We talked about this previously. One of the potential advantage of the VMAT is provide a possibility of employing IGRT. So compared with the normal CT, traditional CT, CBCT could achieve qualified medical images, will deliver lower dose to the patients. Hence, in this way, the cone beam CT could enable radiotherapists to correct the position of the patients and monitor the anatomy structure of the patients where we are doing the radiotherapy, especially under the helping with the fiducial marks. So, for the sake of achieving all of this, we need to sacrifice something, and that something is the resolution of the image. Compared with the traditional CT, the resolution image of the cone beam CT is relatively poor, but it is acceptable for the radiotherapy. Okay, once we have the helping from the cone beam CT and the fiducial marks, we're going to collect the data. We're going to take 10 to 15 patients VMAT prostate plans and collect all of this daily cone beam CT data required where the patient was on treatment and doing the following. And map all the setup shapes that were required to align fiducials. So in here, this step will assist us to investigate the relative accuracy of TAR2-based initial patient setup versus cone beam CT-derived prostate localization. Once we have mapped all the setup shapes, we're gonna calculate the dose contribution. So we're going to rely on another software which is called MIM. So by using the MIM, we can match the CBCT images to the treatment plan and to determine the PTV dose and OAR doses. Once we have all of this information, the dose distribution, tumor's position, OAR's position, we can measure the range of separation between OARs and PTV and assess the impact of current margins and reduced margins. Establish a new internal margin on OARs and possibly GTV or PTV. So as we talked before, the VMAT is an advanced form of intensity modulated radiotherapy. Is that means that the VMAT always is better than the IMAT? The answer is not true. Many reporters report that the VMAT actually could lower the radiation dose to the bladder and retinal, but at the same time, other people said the IMAT could lower the radiation dose to the bladder and the retinal. And there has some conflicts with the double arc technique and single arc technique. Some people said double arc technique could lower the dose to the bladder and retinal. Some people said single arc technique could lower the radiation to the retinal and bladder. So what's the problem? Why they have the different results and their conflicts? So I guess one of the reasons is there are so many unstable factors. The patients they are different. We can't regulate all of these factors. So how we eliminate these differences is really crucial. So for some general patients, we use general methods to create general radiotherapy plans for these general patients. But for some special patients, we need to use special methods to create special radiation therapy for these special patients, which means that the price and cost of this special plan will be higher and higher. So we need to find a way to deal with this problem, and we need some helping. That helping is come from the machine learning. The machine learning basically is a program to effectively perform a specific task without using explicit instructions, relying on patterns and interference instead. The only thing that humans need to do, except programming this program, we need to do is to train the data, is to train the program, feed the program, teach the program, let the machine learning program make the correct decision. And the combination of the machine learning and the radiotherapy will improve the radiotherapy outcome significantly and decrease the radiotherapy planning cost, which will include time, money, labor, and software and hardware. And of course, some people definitely will lose their job because of this. Okay, so for the treatment planning system, so basically there are 3 treatment planning systems. One is called Pinnacle, developed by the Philips Healthcare. Another one is called Monaco, developed by the Alcata. And the third one is called Eclipse, developed by the Varian. In this project, we're gonna choose these 2 TPS, the Pinnacle and Monaco, since these 2 is available on the Linux of Alcata. All the machine learning program is based on Python script. So in this stage, we're gonna teach machine how to do the correct decision by using the Pinnacle VMAT plans with current margins and the Pinnacle VMAT plans with the SABR-like margins. Once we have the class solution from the machine learning, we're gonna transfer the class solution from the Pinnacle to the Monaco and compare the quality of the plans with the Pinnacle plans to see if these plans in the Monaco is effective, is available. Yeah, and I'm truly sorry, Pinnacle. Okay, here is my mind map. We basically have already covered all of the proposal, literature review, presentation. Here is something about collecting data and machine learning and test the data thesis, presentation, and lose all my hair. It's not that bad actually, since people always say that what doesn't kill you makes you stronger. Thanks, everyone.
Okay, move on. Martin?
So what is the source of data for your study, Yutong? Is there a patient set you have access to? Or do they need to acquire data for new patients?
Maybe it's in old patients.
Yeah.
From the database, something like that. Collect their quantum beam CT data, these images, and do investigate.
And to drive machine learning, you need some features and you need some outcomes. So can you just describe what the features are and what the outcomes are that the machine learning's
Yeah, it's a little bit complicated since it's reverse plan. We're gonna set a goal and let the TPS satisfy us. And machine learning actually is helping the TPS challenge itself, break the limit to satisfy us goal and do it better, something like that.
Right.
Is that the question?
Sort of. I mean, you're talking about assessing the impact of reduced margins.
Yeah.
So how does that work practically? How do you assess the impact of reduced margins? Do you have to recalculate those?
Yeah, recalculate the dose use that software, the mean.
Yeah.
Recalculate the dose to see what will happen if we reduce the margin. Is that will cause a really negative effect to the organs at risk case? Is that will deliver enough dose to the tumors? Yeah, something like that.
Right.
Yeah.
So I guess with the CBCT, you're assessing shifts between fractions.
Yep.
Do you know whether there is an impact of motion during a fraction, like during the treatment delivery?
What's the pattern?
So the prostate moves from one fraction to the next, one day to the next.
Yep.
Does it also move while the beam's being delivered?
Yeah, right.
And is that a factor?
Yeah, it will. Prostate will move during the delivery treatment. So that's the point of quantum beam CT. We can monitor the autonomy structure. So this is a new technology. Something like in the treatment, we're gonna take quantum beam CT images every 5 minutes, and to see if it's matched. The beam is directed to the tumor.
You don't have that data because you're using an already acquired set of data.
Yeah.
So then you don't have every 5 minutes.
Yeah, for now we don't have. They said they're gonna apply that in the future.
Thank you.
Yeah.
Any other questions? fine. So I have a question. Last one.
Yeah.
So you mentioned you're using fiducial markers for some
Yep.
algebra techniques. Do you know the challenge when you use metallic fiducial marker in the planning? Do you know what would be the challenge when you use fiducial markers?
Oh, it's hard to recognize.
When you use marker, then
As
yes, metal artifacts. Yes.
Oh, right. The artifacts,
Yes.
the scattering something. Yeah.
So that is a big challenge for planning when we have fiducial markers.
Yeah. Yeah.
Any other questions? It's a good one.
All right. Thanks, everyone.